Hello everybody, I'm Jumai. I'm with Group 6 and we're going to present a policy about Mental Health, Parity and Addiction Equity Act. Our presentation will consist of introduction, history, policy description, policy analysis, and recommendation. What exactly is the Paul Wellstone and Pete Dominici Mental Health, Parity and Addiction Equity Act of 2008, or more commonly known just as Mental Health, Parity and Addiction Equity Act of 2008. This is an act, a federal law, that was enacted to ensure that health plan groups and insurance company do not discriminate and will not discriminate against mental health and substance disorders coverage. Prior to this law, there's a lot of discriminations against mental health and substance use disorder treatments. A lot of time when people are seeking coverage benefits for their mental health problems and their substance use disorder, a lot of time insurance will deny them or give them a very little coverage, unlike the regular medical or surgery treatments. The reason it was called Paul Wellstone and Pete Dominici is because these two senators was one of the one who pushed hard for this law to be passed at the Congress level. And this law is one of the gateway to help a lot of mental health treatment seekers to get proper help. Now we're going to talk about the history, why this law was proposed and why it was passed in the end. In 1992, Senators Pete Dominici from New Mexico and John Danforth from Missouri introduced the first federal mental health parity legislation in Congress. It failed because there's not a lot of support for this law, and at that time the awareness of how devastating mental health is without any good support from the insurance and health plans groups was very low. And the door slightly opened in 1993 and 1994 when President at the time, Bill Clinton, was in the stage of trying to reform the healthcare efforts, which unfortunately also failed. But that helps to propel this law. This time, in 1995, Senator Dominici collaborated with another senator, Paul Wellstone from Minnesota, and introduced this act with more extensive parity bill and merged it directly to health insurance portability and accountability, or as we more commonly known as HIPAA. And finally, in April 1996, 68 to 30 of them voted to approve parity as an amendment to the HIPAA legislation, and that was a great news for the mental health world. And it was in October 2008 that the Mental Health Parity Act and Equity was finally made federal law by, at that time, President W. Bush. And it was finally passed because it was a stipulation by President George W. Bush for approving the Emergency Economic Stabilization Act because at that time, as we remember, 2008, we have a economic crisis. A lot of financial institutions needed to be bailed out, and which also sent America into financial crisis. So for President Bush to approve that financial stimulus for the financial world, he made a stipulation that this law has to be put as a federal law, and it was a great news for everybody.
The policy description. First implemented in 2010, the Mental Health Parity and Addiction Equity Act is a federal policy that bars health insurance plans from creating barriers to access for both mental health as well as substance use disorder treatment. Mental health and substance use disorder, as we know, often go hand in hand. So, accounting for both of these aspects of health was a critical part of the Act. An amendment to a 2008 law, this Act ensured that plans could not discriminate coverage for these services, and it created a more level playing field for mental health care as well as substance use disorder treatment. It said that physical conditions and mental health conditions should be treated equally, and put in place certain structures to ensure that. Due to the burgeoning mental health and substance use disorder crises in the United States, the Parity Act has become necessary to open access for everyone. And for this reason, the Act obliges insurers to offer benefits for both mental health and substance use disorder treatment. It also requires several things from plans and insurers, including to document comparative analyses of non-quantitative treatment limitations, as well as pre-authorization requirements and network composition standards as they relate to mental health and substance use disorder benefits. In other words, not only are the plans now responsible for providing these, but they also are responsible for documenting limitations to providing those coverages. New amendments to the MHPAEA were released in September of 2024 and will go into effect on January 1st of 2025. According to the Department of Labor, these amended rules also impact state and governments' health plans, now dictating that they cannot opt out of the rules set forth by the MHPAEA. So this is a new umbrella over an additional subset of health insurance policies who are now also subject to these mental health parity rules. Thus, the onus is on the plans to not only provide coverage for these benefits, but also to investigate where the benefits are not met in order to address them. They must be accountable for demonstrating the results of their investigations, and they must allow state departments, authorities, and other individuals who request this evidence to view it. Mounting scientific evidence also demonstrates the interrelatedness of mental and physical health conditions. And according to the editorial, integrating mental health into primary health care, mental health is often comorbid with many physical health problems such as cancer, HIV and AIDS, diabetes, as well as tuberculosis. And issues such as poverty can exacerbate mental health conditions as well as physical health conditions. For this reason, the Mental Health Parity Act is necessary to curb other healthcare costs, and gaps in healthcare coverage in the United States can propel many in this country into poverty. This has deterred many from seeking much needed mental health and substance use disorder treatment, in addition to doing without other physical and other medical interventions.
When researching the Mental Health Parity and Addiction Equity Act, we did find quite a few limitation and policy issues. Amongst those were unequal coverage in comparison to physical health insurance, limitation on coverage, implementation issues, and the government heading towards a more politically conservative direction. So although this act was implemented with the goal of limiting and discouraging discrimination of coverage differences, that is still an ongoing issue. Many Americans have reported having to choose between their physical and mental health. A lot of the times choosing their physical health, and this being because a lot of the times physical health insurance packages offer more benefits and more coverage in comparison to the mental health insurance packages that could be offered in many places, which leads us into that second policy issue, which is the limitation on coverage. So although this is an act that was enacted for the whole United States, it's not like Obamacare, where it is reinforced and funded by the government. At this time, it is left at the state's discretion, and the states are able to put limitation on what that coverage looks like and who is required to put that coverage, which again leads us into that fourth policy issue, which was the implementation. Because it's at the state's discretion, currently there isn't really any consequences for not following through with this policy or this act. At this time, it's more of a list of requirements or recommendation as to what they would like to see for this policy, but not necessarily straightforward or strict, leaving a lot of leeway and loopholes for a lot of agencies and states to kind of leave open for that discrepancies in between the physical and mental health coverages. And the last policy issue that we foresee happening is with the government going towards a more conservative direction. We do foresee this being an issue with future funding and overall just implementation moving forward. The implementation the first time around did affect how effective this act could be, and we see it going, if the implementation is not implemented correctly the second time around or moving forward, we can see this as an ongoing issue. So some proposed changes that we looked into kind of addressing those issues that we've identified is proper implementation is the first one and the biggest one that we really wanted to see happen. So we want to see effective and equal consequences for lack of enforcement, equal to that of physical health insurance. So there being fines, there being write-ups, there being some kind of implementation to make sure that this is being reinforced, as the consequences are kind of what push to enforce that the law be followed and enforced. And above all, the Department of Labor and the Department of Health and Human Services are currently in charge of this. So we feel like they should step up with more rigorous compliance monitoring and transparent reporting requirements. We believe that if they are able to monitor more on that compliance and have more transparent reporting and data collection, this could help with implementation in the future, but also it could help with making sure that they can monitor where those discrepancies are coming from so that they can improve moving forward. We believe that with the proper implementation, the three factors of feasibility would be maintained and obtained. So overall, we recognize that right now 73% of Americans recognize mental health as a part of their overall health. So politically, we do know that this is feasible. We recognize that most Americans, over half of Americans, want this and require this to improve their quality of life, which leads us into that economic feasibility. Overall, we recognize that with better quality of life, there's more chances for employment, better work ethic, and on top of that, we would prevent crisis services. So if we focus on preventative services instead of recuperative services, we can help limit how many services we need to implement moving forward, which would help with the overall health and quality of life here in America. And the third, administrative feasibility. Currently, we recognize that this could be a limitation, but we recognize that if changes are implemented, data collection was being implemented, and there was that transparent reporting and monitoring. We do think that the administrative could be feasible because we recognize that currently there is a lack of data as far as the reinforcement, and we believe that with that collection of public feasibility and economic feasibility, that the administrative part of this implementation could enact itself. Overall, we do recognize that the Mental Health Parity and Addiction Equity Act was meant to provide funding and support for most people and help discourage that discrimination that is currently occurring between insurance coverages. We do understand that this is an ongoing issue with a lot of limitations, and a lot of the times this is affecting more than half of Americans. So if this was implemented and improved, this would also benefit more than half of Americans. We do recognize that, like with many other acts and any other policy, this has to be continually updated and adapt to the economy and to the public that it is servicing. But currently, we do recognize that with these changes, this is something that is very feasible. We appreciate you guys watching our presentation. I hope you guys enjoyed it as much as we did. We found this topic to be very interesting, especially as future social workers and possibly future clinical social workers. This helped us understand possible limitations that our clientele might be facing when looking and seeking for services and support. So this was definitely very interesting to us. And if you guys have any questions, feel free to reach out to any of us.